Good evening, everyone. Today I'm going to present a case presentation and it will be moderated by Dr. JSN ma'am. So 53-year-old lady came to the OPD with a history of floaters. The floaters were in sudden in onset and it was not associated with any blurring of vision, flashes of light, pain or redness. The patient gives no history of trauma or lifting heavy objects. Past ocular history. There's history of cataract surgery in the right eye 2 years back elsewhere, as well as history of an uneventful cataract surgery that was an extracapsular cataract extraction plus IOL in the left eye 1 year back. Resuturing was done in post-op day 2 for positive for serial test and hypotony. Personal history. Patient is a known diabetic for 15 years and is under control and is a known hypertension for 25 years on treatment. Family history. There is no significant family history. On clinical examination,
Arush, 1 minute. So you mentioned uneventful. Don't you think POD2 resuturing is an eventful thing?
Ma'am, I said about the family history.
No, you go back. You told that past ocular history of uneventful cataract, right? Yeah. Then you told POD2, there was some event, right? Resuturing has been done.
Yes, ma'am.
So maybe you need not mention it is eventful or uneventful because there is an event on the next day. You could have mentioned history of cataract surgery, followed by that resuturing is done. See, when you take up resuturing for next day, it is an event. Okay? Yeah.
Ma'am, I wanted to specify like no intraoperative event was there, like no dissense of the capsule. So
Yeah.
that's I wanted to signify in the history.
Right. Okay. But
Yes, ma'am. I
cataract,
will not.
it includes, yeah. Sure.
Yes. On clinical examination, general examination, patient is moderately built and nourished, conscious, oriented to time, place, and person. No pallor, icterus, clubbing, cyanosis, lymphadenopathy. She was afebrile. Heart rate was 72 beats per minute. BB was 143 by 83 mm of Hg. Cardiovascular and respiratory system were within normal limits. On ocular examination, the head posture was normal. There was no facial asymmetry. The extraocular movements were full and free. In the right eye, the uncorrected visual acuity was 6.1.5 and the best corrected visual acuity was 6.6 and 6. While in the left eye, the best corrected visual acuity was 6.6 and 6. On the anterior segment examination in the right eye, the lids and conjunctiva were normal. Cornea was clear. The AC was squared with a Von Harris grade of 4. The iris had a normal color and pattern. The pupil was round, regular, reacting to light, and there was no RAPD. The anterior vitreous face was clear, and the Goldman applanation tonometer done at 12 o'clock was 17 mmFg. In the left eye, the lids and conjunctiva were normal. The cornea was clear. The AC was squared with a Von Harris grade of 4. The iris was of normal color and pattern. The pupil was round, sluggishly reacting to light, but no RAPD. It was a pseudophakic in both eyes. In the left eye, the anterior vitreous face shows pigments, and the pressures were 18 mm of Hg.
Again here, since you mentioned an eventual cataract resuturing, and it's also a good idea to mention whether the lens, you could make out whether the lens was in the back, well centered, slightly decentered, or any vitreous in AC. Vitreous in AC, even if it is a negative finding, I think better to mention having a history of,
Okay, ma'am. So on fundus examination, on the right eye, the media was clear. The disc was within normal limits. On the macula, there were yellowish lesions that were drusen. In the superior nasal quadrant, there was a pigmented lattice. In the left eye, the media was clear, slightly hazy due to there were pigments in the anterior vitreous face. The disc were within normal limits, and at the macula, just temporal to the macula, there were drusens. Then, in the superior nasal quadrant, there was a retinal detachment, and a break was noticed at 11 o'clock, with lattice degenerations at 12 o'clock and inferiorly at 5 o'clock.
hold on. So what is
Rhegmatogenous retinal detachment with macula on.
Can you
In the
specify
left
the
eye.
eye? Yeah. So left eye, rhegmatogenous. Yeah, supranasal.
supranasal,
Okay,
yeah.
supranasal detachment with macula on, with lattice in the attached retina as well. To complete, right eye also has lattice, right? Okay. And pseudophakia, of course, whatever you have to add. Okay, next.
So
So
this is the
it's one second, Arush. It's going to be interactive from one. Okay, Arush is just a media for presentation. This is exclusively for PGs. Okay, and every slide after he finishes the presentation is your exam question. I have gone through all of your previous papers, so I want you to pay attention. Okay, you can answer something absurd also. Never mind, but please attempt to open your mouth and answer. Okay, go ahead.
So this is an Optus image of right eye, and you can see the media is clear, the disc is within normal limits, and you can see there is drusense temporal to macula. Well, this is the Optus image of the left eye. So in the upper right image,
Hold.
upper
Arush, hold. Somebody else can describe.
left eye.
So whenever you mention optos, it is a pseudo color image rather than a full. So it's a pseudo color optos image. Yeah.
Color optos image of the left eye. Media is clear.
I think that much only you could make it here. So how does it look like when you see a? Could you tell it is fresh or old? Could you make out that? So what
It
do you look
appears
for?
more corrugated. The retina that we can see,
Yeah.
it doesn't appear flat. Like in an old RD, we won't be able to make out the corrugations that we normally would appreciate in a fresh RD.
No, on the other hand, in old RD, actually retina will be thrown into folds. It might look more corrugated as well. Okay. The thing is, there are not much retinal folds. In first place, actually, why it is recomendogenous RD? Because obviously you have a break. So that is one. Second, fresh RD, there are not much retinal folds. If you see the edges of the break, they are not rolled, and for that matter it is localized, right? If it is an inferior RD, it can be there for years. Very unlikely for a superior RD to remain localized, although I won't say it's not possible. So this looks like a fresh RD, right? um, yeah, so fresh recomendogenous RD. There are other lesions as well, not very clearly seen in this picture though. Okay, and it is slightly bullous over that part. Actually, if you see the extent of RD is more than that. You see that, that demarcation means watermark kind of a thing, but it is bullous there. Okay, yeah, please.
So, in the case summary, it's a 50-year-old lady came with the complaints of sudden onset of floaters in the left eye for 3 days with rheumatogenic retinal detachment sparing macula in the superior nasal quadrant with primary break at 11 o'clock and a lattice in the inferior temporal quadrant. Right eye has pigmented lattice in the superior nasal quadrant.
Hold. So, sudden onset floaters with sudden drop in vision. What you will think other than RD? Yes, vitritis. Good. Especially when vision is 6/6, it might be a vitritis as well, right? So these two things mainly with him. Okay, yeah. Then
So now moving on, so to the clinical features of retinal detachment. So the symptoms. So the patient will see photopsia, that is the flashing of light. Usually, it is with the head or eye movement. It's usually seen in temporal periphery, and the mechanism is uncertain, but may be related to the traction on the optic disc and possibly at the sites of vitreoretinal traction. The patient may experience floaters, which are spots, cobwebs, or flies. These are generally a mobile vitreous opacities. Patient may also complain of blurred vision and visual field defects. Patient will complain about blurred vision if it is starting involving the macula. Now, signs of retinal detachment. The first is RAPD. It is usually present if there is an extensive retinal detachment. The intraocular pressure is lower by around 5 mmFg compared to the fellow eye. If the intraocular pressure is extremely low, it may be associated with choroidal detachment. If it is raised, it may be characteristically raised in Schwartz-Matsoa syndrome, in which the RRD is associated with mild anterior uveitis, often due to the dialysis secondary to a previous blunt trauma. Iritis is also common, but it is usually mild. Occasionally, it may become severe enough to cause posterior synechia, and we may miss the underlying RD. Also, the other sign is tobacco dust.
hold. What is Schaffer's sign or tobacco dust? Okay, how does the pigments come? From via the open break, right? Yeah.
Now, the retinal breaks. Retinal breaks are the discontinuities in the retinal surface. They are usually seen red because of the contrast between the neurosensory retina and the choroid. The retinal signs may be present on the basis of two things: the duration of the RD and the presence or the absence of the proliferative vitreous retinopathy.
Yeah, 1 minute. So, what are the types of breaks you know? Do we have a slide on that? I don't recollect. We don't. Okay. So, which is more, dangerous or should I ask why? Sure. Something progressive is happening, right? So, whenever you see a tear, it is more signal. Means you have to treat it. What about holes? What is the reason for holes? Tears obviously due to yeah, thinning atrophy, right? Usually associated with lattices or sometimes even otherwise also. So, what is the definition of GRT? I think GRT we have a
Yes,
slide.
sir.
Yeah, okay, fine. What is the difference between dialysis and GRT? Yeah, so GRT more than 90-degree. Dialysis, irrespective of the size, it is just a tire at the ora. Where is the vitreous attached in the dialysis and GRT? Posteriorly attached. Very good. Good.
So now we will look at the different points between the fresh retinal detachment and the long-standing retinal detachment. So in fresh retinal detachment, there will be a loss of the choroidal pattern. It will, if it's an RRD, it will have a convex configurations with corrugations. It will be a slightly opaque with dark blood vessels, and there will be a loss of contrast between the arteries and veins in the detached retina, and obviously the presence of the break. In the long-standing retinal detachment, we can see demarcation lines, as we can see in the first photo. Then there may be an immobile retina due to PVR. It may be a very thin and atrophic retina also. There may be a secondary intraretinal cyst, which you can actually see in the photo B and C, also associated with PVR changes. So this is the first photo we see in the case, which looks more like a fresh RD as compared to the photos below, which all sees like a long-standing chronic retinal detachment. So finding the break in the
Someone can explain this?
The break is present close top. Then subretinal fluid will be on the higher side. That side the break will be there.
You don't see the break first. You see the detachment and you find the break, correct? So you can explain that way?
The higher side subretinal fluid. That side the break will be there. If it is an inferior bullous RD, then and on yeah, it is above the break will be present above the horizontal meridian.
So now moving on to the differential diagnosis. So the differential diagnosis of the case we just discussed would be an exudative retinal detachment. So now moving on to each one of them on how to differentiate them. So this is a table which signifies the difference between the three type of detachments, that is a rhegmatogenous, tractional, and exudative. So on the basis of history, so in the rhegmatogenous detachment, there may be history of aphakia or myopia. The patient may have photopsia or floaters and field defects, as we have discussed before. In tractional retinal detachment, there may be a history of diabetes mellitus, ROP, sickle cell.
Arush, it is extensive. We'll just go through the important points. See, regma, basically there will be a break. Okay? Corrugations. Exudative, no break. It will be smooth. Some reason for it, there will be a clue like inflammation or mass lesion, shifting fluid. Okay? Tractional, obviously there will be an underlying disease like trauma, diabetic, pain occlusion, whatever. But still, tractional detachment can also have a combined detachment, like presence of break like doesn't rule out a tractional as well. So you have to look for what clues you have in the same eye as well as the other eye. But first, you rule out a rhegmatogenous RD. And whenever you see something like rhegmatogenous, but you have a suspicion of exudative, okay, before taking up for surgery, rule out the exudative cause as well. Matlab, it looks like rhegmatogenous or exudative. Best thing is do all possible investigation, rule out exudative. Okay, exudative RD, if you operate, it might become even worse. Correct? So, most important thing in any detachment is first find out whether it is rhegmatogenous. Right? Next.
So
Yeah,
should
yeah,
I
skip
explain
it,
the?
skip it, skip. They'll sleep. Yeah. So, what is retinoschisis? Today, Arush is not the presenter. Okay. How is it different from detachment? First, what is the definition of detachment? RP. Okay. So, this retinoschisis happens within the other layers. Actually, technically, RP is also a layer of retina, but still. Okay. What are the types?
Typical and reticular.
That is types of degenerative. But what are the types of schisis as? What is the other type you know? What is XLRS? Okay. Okay, you go through this one.
So the retinoschisis is believed to develop from microcystoid degeneration by the process of gradual coalescence of degenerative cavities, resulting in the separation of splitting of the neurosensory retina into inner and outer layers, with serving of the neurons and complete loss of visual function in the affected area. It can be of two types, typical and reticular. Typical is more common, and the split happens between in the outer plexiform layer, while the reticular, which is a less common type but a more dangerous one, the split occurs at the nerve fiber layer. The photopsias and floaters are usually absent. It is bilateral in up to 80% of the cases. In early retinoschisis involves extreme inferior temporal periphery of both fundi. The elevation may be smooth, convex, thin, and relatively immobile. The retinoschisis is associated with approximately 3% of the full thickness of retinal detachments. Now, this is a table showing the differences between the retinal detachment and the retinoschisis. The retinoschisis causes an absolute scotoma, whereas retinal detachment causes a relative scotoma. The tobacco dust, hemorrhage, both may be present in the vitreous and retinoschisis, but it is more commonly observed in rhegmatogenous retinal detachment. The retinoschisis has a smooth surface and usually appears dome-shaped, in contrast to the rhegmatogenous retinal detachment, which has corrugations and irregular surface. But in long-standing rhegmatogenous retinal detachment, the retina may appear smooth and thin and may have a similar appearance as retinoschisis. But the other features of the long-standing retinal detachment of rhegmatogenous type will not be there, like demarcation lines and the intraretinal cyst. Another important feature which can be differentiated is the RPE. The RP is usually normal, underlying RP is usually normal in retinoschisis, while it may be atrophic in a long-standing rhegmatogenous retinal detachment. Now the next
And
slide.
to add one more point, the intraretinal cyst, which you see in a long-standing detachment, is actually an acute retinoschisis. Again, it's a schisis only, but it's due to long-standing detachment. It's a kind of secondary retinoschisis, actually, to be put. Okay.
Now the next differential diagnosis is choroidal detachment. So the symptoms in choroidal detachment would be like photopsia and floaters are usually absent because there is no vitreoretinal traction. A visual field defect may be noticed if the choroidal detachment is extensive. Now the signs. There is a low intraocular pressure because there is a concomitant detachment of the ciliary body. The anterior chamber may be shallow is in eyes with extensive choroidal detachment, leading to a non-pupillary block angle closure. The elevations are brown, convex, smooth, and relatively immobile. Usually, four lobes are present. The temporal and the nasal bullet tend to be more prominent. The elevation do not extend to the posterior pole because they are limited by the vortex veins entering the scleral canals. However, in contrast to the retinal detachment, they extend anterior beyond ora serrata. The treatment is usually directed towards the cause, and we can drain it via partial thickness sclerotomies if required.
How many of you have seen a choroidal detachment? It was post. It would be usually post something, right? Trauma, surgery. Yeah, so post-op it's very common, right? So what happens if we don't treat a choroidal detachment? Why don't you just leave it? Yeah, hypotony that vicious cycle will have. It can lead to exudative detachment. Long standing, it can cause retinoretinal adhesions. To be very frank, it is not easy to diagnose a CD. You have to have a suspicion. Most often, you diagnose that way because it doesn't produce any gross structural alteration. You just feel happy that you see aura well and finally realize it's a CD, right? Yeah, and causes any hypotony, as he already mentioned, and the other tumors you must be knowing inflammation, tumors. So, most commonly we see post operative, and all rhegmatogenous retinal detachment cases, before taking up for surgery, you have to rule out CDs clinically or by ultrasound, especially when IOP is like 0, 2, long standing detachment. inflammatory component is prominent. So rule out a CD. Okay. Next slide.
Now, moving on to the treatment modalities in the rheumatogenic retinal detachment. So, first we have scleral buckling procedure, then a PPV, that is sparse planar vitrectomy with or without scleral buckling, then pneumatic retinopexy, and laser demarcation of the detachment.
See, all you except for laser, other three or the basic is that only seal the break. All the other three work. I am saying this case, why not pneumatic retinopexy? See, this is a localized RD. Okay, I understand that you don't want to go to VIT. Okay, so you can either choose buccal or pneumatic retinopexy. Why not pneumatic retinopexy? Very good. So multiple lesions, right? Inferior lesion was there. Superior also one HST is there, one more lattice is there. Good. Then buccal. Why not vitrectomy? Yeah. So whenever possible, no, we prefer buccal. Okay, it's an extraocular, less complications, with proper technique and proper case selection. Nothing like it. Okay, and vitrectomy because this case first of all localized and anterior break. You see the breaks well, right? So buccal is the maybe my first choice, but it depends surgeon to surgeon. Okay. More than that, it's a superior detachment. Anyway, it will progress. See, if it is a long-standing inferior detachment, if patient is not getting fitness, those cases still you can consider laser. Okay, but not for superior detachments. Okay, next.
So, now moving on to the scleral buckle. It is sometimes referred as a conventional or external retinal detachment surgery. It is a surgical procedure in which material sutured onto a sclera, explant, it creates an inward indentation. The purpose is to close the retinal breaks by opposing the RP to the sensory retina and reduce the dynamic vitreoretinal traction at the sites of local vitreoretinal adhesions. Now, the indications of scleral buckle are if there is a retinal dialysis, there is lattice generation with atrophic holes, if there is a young patient with an anterior breaks, and there is no proliferative vitreoretinopathy. Now, moving on to the procedure.
So you will say what is this?
So first we do a peritomy, a 360-degree peritomy. After that, we need to identify all the muscles and tag each muscle, and we have to put the suture inside it while tagging. And it's very important to get the whole muscle and don't pierce the muscle or any arteries around. Uh, then after that, we need to check whether the movement is okay or not. Like we are able to generate enough traction after tagging. Uh, After that, we need to do the IDO and identify all the breaks.
Okay. Okay, Arush, you go through.
So, just like he
After
explained,
muscle tagging.
so to localize the retinal breaks, we will actually see.
You left quadrant check. For the same reason I told to do. So quadrant check is most important. After muscle tagging, please check all the quadrants. Okay, for scleral thinning. Whether you will be able because there if you don't check, you land up in thinning, then you realize it becomes cumbersome. Okay. So quadrant check, two things. One is scleral ectasia and vortex weights. Okay. Then
So now we have to localize the retinal breaks. So while localizing, if it's a small break, we take a single point in the center. While if it's a large osteotic, we take 3 points, one at the posterior margin and one at each of the two horns. And if it's a dialysis, we will take the two ends and the posterior extent at the midpoint. Now we will try to make the adhesion between the retina and the choroid via cryopexy. Then we will take the anchor sutures to fix the explant configuration, which can be either by scleral tunnel or silicon bands. If we are using more than two radial explants, then we have to use encirclage. And depending upon if there is a subretinal fluid or not, we have to decide about a drainage. And then finally we will see the different position of the scleral buckle and if it is exactly covering uh, the holes and the detached retina, because that is one of an important factor that the surgery is failed. And then finally is the closure.
so two, three things. One is the buckle should cover at least 1 clock or either side on the break and 1 to 2 millimeter on either side, like anteroposterior extent. More for a posterior extent though. And depending on our hospital, we commonly use 279, 276, and 277. Okay. To explain about the buccal elements beyond the scope of the class, so I reserve it to you to read little bit about it. And it's our institute is one of the institutes where still buckle done actively. So that is one. And then the scleral tunnels, we use it for encerclage. Here, routinely for all cases, we use encerclage. Okay. It helps to retain the buckle in its proper position, the broad buckle, and allows uniform indentation. Okay. And explant configuration for more anterior breaks, we use 276 to 77. Larger breaks and posterior breaks, we use 279. I think that much you should know. And drainage, discretion of the surgeon. Mostly drainage is better. Okay. But if you don't have enough fluid, if it is localized detachment where you cannot drain near a break, so those conditions we can still differ. Okay. And finalization, what he means, after you put anchor suture, you temporarily tighten, then you insert the buckle, you tighten and see. After drainage, everything done, for example, to form the globe, you inject air and those things, After you do all these things, last, finally, you tighten once and check with the indirect whether the indent is adequate. That is what is finalization. Finalization of the suture knots. Okay. Then closure, buckle, better to close tenons and conjunctiva separately, especially in children. Right? You don't want any buccal exposure or infection. Correct? May not be adequate in very high bullous RD, where in bullous RD it appears the breakup is more posterior, right, to parallax. So those cases you feel the localization may not be accurate. There you would first drain, make the retina flat so that you get accurate localization. Okay, generally we don't follow here, very selected cases. Okay, where do we do? In normal cases, you're asking, right? First, better away from break, but within the place where you have enough fluid. Okay, yeah, so where it's a very common sense. So where you drain and you get enough SRF drainage that you reside, preferably away from break. Very shallow retina, what can happen is retina can incarcerate, vitreous can incarcerate. Those things you want to avoid. Not along the horizontal meridians, of course, because the choroidal vascularity, those steps are there. Easily accessible for your hand. For example, temporal quadrant. Okay, so these things. Okay. Yeah. So avoid directly adjacent, like it should not be through the break. Otherwise, vitreous everything will come, right? Yeah. So that's what I told you, I think. So most of the patients have multiple lesions. It's only isolated. Yes, you might technically get away with the segmental only, but putting a belt buckle helps. It doesn't move. The indent is very uniform. Okay. Tire also same, right? So the sponge carries high risk of infection, so we don't use it. Okay. And what? So this one is encircling band. So we use 240. Okay, encircling band. Next.
Now moving on to the complications of the scleral buckle, it can be divided into intraoperatively, early postoperative, and late postoperative.
And this is available in your handout, so you can go through. Most important is recurrence. Okay, especially when missed breaks, uncovered breaks. So those things. It's not because of the technique, but second PVR. You take cases there is already PVR, and other complications are not really much. Then buccal exposure, buccal infection, those things. And the most common complication in attached retina, otherwise the surgery is success, but still complication with thin epiretinal membrane, pigment migration, those things. Okay, otherwise it's a quite good technique, not much complications. Proper case selection and proper technique. Okay, skip this slide.
Now moving on to the second surgical modality, that is a pars plana vitrectomy. So now the indications in of the pars plana vitrectomy are in RRD when the retinal wakes cannot be visualized due to media haze. There are giant retinal tears, or there is a large posterior tear in the presence of a PVR. In a TRD, it is also used in TRD involving or threatening macula.
And all complicated forms of retinal detachment, okay, like coloboma, just he mentioned, RRD, endophthalmitis, post-trauma, okay, all this and recently we are leaning more towards vitrectomy because of the good instrumentation and good visualization, right?
So the goal of the surgery is to separate the posterior hyoid from the retinal surface to remove the epiretinal tissue in order to release a central or the peripheral retinal traction and to close the retinal bricks if present. So now this is the steps and the technique of the PPV, in which we first do a belt buckle, then we create 3 sclerotomies, one the superior temporal, inferior temporal, and the superior nasal quadrant. We can use then we have to do a core vitrectomy, then we do a removal of the posterior hyaloid, then the removal of the vitreous around the break, because that is the one which is causing the traction. Then we remove, depending upon the pre-retinal membranes are they present or not, because if the pre-retinal membranes are present, there will be a funnel like configuration mostly seen in trauma patients. Then we do a fluid gas exchange, a fluid air exchange, then we laser to the break, and then finally we do a tamponade using an oil or a gas.
Belt buckle, because see, vitreous base is the strongest point of attachment apart from optic nerve and macula, right? So most of the breaks are seen at the posterior border of vitreous base. Okay, when you do also, I mean spontaneously also, intraoperate also, when you do manipulations, vitreous base is one place where you can have progenic breaks. So we put a belt buckle to support the vitreous base. Any traction, anything is there to prevent mostly post-operative complications, recurrence, anterior PBR, and stuffs like that. Okay. Initially, we were not able to do very good anterior dissection because of the visualization. Now, because of good instrumentation, visualization, we still we can technically manage without a buckle, but phakics and those patients where you feel like you may not be able to shape the peripheral vitreous properly, it is safer to use a belt buckle. But putting a belt buckle doesn't mean that you need not do a base dissection as well, right? So the purpose of belt buckle is to support the vitreous base rather than supporting the primary break in a vitrectomy, right?
Now moving on to the complications, it can be again intraoperatively or postoperatively. So in the post-operative complications, we have retinal breaks and RRD can happen, and there are retinal folds. There might be inflammation, particularly in patients with diabetes, and there might be membranes and traction may be present in the patients of diabetes. While making a tamponade, we can actually cause and raise intraocular pressure. There may be a silicone oil associated glaucoma, while the other mechanism of glaucoma may be ghost cells, inflammatory, steroid induced glaucoma. The angle closure can also result from a seriochoroidal effusion. The formation of cataract may be due to a gas induce, in which a large or long-lasting intravitreal gas bubble typically give rise to a posterior subcapsular cataract. It may be a silicone-induced one, so almost all phakic eyes with silicone oil eventually develop cataract. And it may be delayed, which may be following vitrectomy. A substantial nuclear sclerosis becomes is very common. And the final complication may be a band-shaped keratopathy.
So I would slightly like to differ here. Not almost all silicone oil filled eyes you see cataract. Actually, vitrectomy per se doesn't cause cataract. And that at least what the study says. So it causes progression of pre-existing nuclear sclerosis, right? But most commonly, you see a transient feathery cataract in the first post-operative week. That is because of the fluid air exchange or the gas, okay, gas-induced cataract. But mostly it settles. Okay, oil induced cataract, I would not say it is because of the oil, it is because of the surgery per se, right? It causes progression of pre existing cataract. And you do combine cataract surgery only if it hampers the visualization, if the cataract is significant enough. Otherwise, you can preferably, in a reg RD at least, you prefer not to combine, right? Okay, next. So what are the specific advantages is, though it is claimed that sutureless, sometimes you need to suture, that is different. Mainly the instrumentation. Okay, the instrumentation is very good. You can work close to retina. It grossly has reduced the iatrogenic complications, right? And your IOP control, it's very good with these instruments, especially valid cannulas. Okay. And rest, I think it comes with the handout. Yeah. Next. And less scarring, less intraoperative time, faster rehabilitation. All these are mostly theoretical, right? Yeah.
Now moving to the next technique, that is a pneumatic retinopexy. So the principle in the pneumatic retinopexy is that the gas has a buoyancy and it floats. The glass bubble has a surface tension that bridge across the brake and tamponades it, which prevents the fluid entry into subretinal space. The RPE pumps takes care of the sequestrated subretinal fluid, and the laser and cryo is done for permanent adhesions between the retina and the choroid. So, for in pneumatic retinopexy, the most important thing is patient selection. So, what are the indications and the contraindications? So, indications are when there is one or more break within 1 clock hour, which is located in the upper 8 quadrants, and there should be no PVR, and there should be an ability to exclude other retinal breaks, like if there is a dense cataract or if there is a dense media haze due to vitreous hemorrhage, then this should not be performed. Now, moving on to the contraindications. The contraindication is if there is a break larger than 1 clock hour, there are multiple breaks extending more than 3 clock hours. That there may be lesions like lattices in multiple quadrants. The break located in the inferior 4 clock hours of the eye should not be used because the gas usually tends to float and go up. And if there are other contraindications are if there is significant traction on the retinal tears, and the patients who are unable to maintain an adequate position, which is very important in the pneumatic retinopexy, and patients with advanced glaucoma because it may like increase, and like I discussed before, a cloudy media. Now moving on to the technique. So first, if we are doing a cryo, is done usually before the gas injection, and laser is done after the gas injection. And then there is a pars plana injection of the gas. If we are using SF6, we use a concentration of 0.5 cc, while if we are using a C3F8, we use 0.3 cc. If to moderate the pressures, we may do paracentesis, and the final thing is posituring. And we have to be very careful, like we don't want to inject too fast, we have to inject slowly because multiple air bubbles if we inject too fast, it can cause multiple air bubbles, and which may lead to the complication I will discuss below. So the complications are usually if the gas is not in the right place where we want it, like it may be trapped in the petit space, it may leak out in the subconjunctival space, which can be actually prevented by applying a cotton bud while removing the needle. It may go to a subretinal space, which I was telling you about in the earlier conversation. That if small break can actually go through small bubbles can actually go through the break and go into subretinal space. There are also incidences of macular detachment in the eyes where it was actually earlier attached. Now we are discussing some of the important questions which has been asked in the previous years. So the first one is the posterior vitreous detachment, which refers to the separation of the cortical vitreous along with the delineating posterior hyaloid membrane from the neurosensory retina posterior to the vitreous space. While the prevalence of the PVD increases with age, it is less than in 10% individuals under the age of 50, while it rises to around two-thirds of the patients above the age of 70. It is usually a spontaneous event, and it may be induced by events like cataract surgery, trauma, uveitis, and panretinal photocoagulation. It may be complete or incomplete. In a complete PVD, the entire vitreous cortex detaches to the posterior margin of the vitreous space, while in an incomplete PVD, which is usually seen in a diabetic retinopathy, we see a residual vitreoretinal attachments which remain posterior to the vitreous space. Now, what is the pathophysiology around the PVD? So, the PVD occurs due to the vitreous gel liquefaction with age, which is the syncysis, to form fluid-filled cavities, which subsequently condenses, that is syneresis. Then it passes through the hole in the posterior hyaloid membrane, which forms the fluid passes through the defect and goes into the retrohyaloid space, detaching the posterior vitreous from the ILM. And there is an acute episode of a PVD in which the patient usually experience floaters, flashes of lights.
How many percent of acute means PVD is associated with breaks or detachment? Most of the times, patient doesn't realize, right? PVD has happened or not. Correct. So almost 20% can be associated with breaks, and any PVD with fitting, you have to closely follow up weekly. Okay, because sometimes first week you may not see the break. Okay, subsequent weekly follow up is needed, at least 3-4 visits. Make sure there is no retinal tear. Right. PVD was one of your exam questions. That's why I kept this slide. Next. So what will you do for this lady? What did we do? This case, you remember other eye also had lattice, whether to treat it or not. She is not symptomatic in that eye. Treat, right? Any lesion in the fellow of RD, close your eyes and treat. Okay, and any HST, like any horseshoe tear, please treat. Okay, rest of the conditions you take a call. Right, family history is positive. Patient cannot come for follow. Say patient is flying to US or something. He says he cannot follow up there. Those cases, case to case, you can take. Better to treat. And any pre-procedure, LASIK, cataract, you have to treat. Right. Next slide. So PVR again has been asked as a sub question. So there are three classifications, two classifications, sorry. So initially there will be only pigments, that is vitreous haze, and second is fold, subtle wrinkling of the inner retina. This is what I told you. Whenever there is fold, you should suspect PVR, right? And the third grade C is fixed retinal full thickness folds. Okay, these are symptoms of long-standing detachment. Basically, nothing but something is proliferating on the surface of the retina, sometimes underneath also. Underneath we call as subretinal gliosis or subretinal bands. Okay, next slide. Yeah, this has been asked n number of times. Okay, I think you can go through the slide.
So, in giant retinal tear, it's a circumferential retinal break of more than 90 degrees, which arises from the circumferential vitreous traction in the region of posterior vitreous space in the presence of a PVD. So, to classify, there are three classifications we can use. On the basis of location, it may be equatorial with posterior extensions, and oral. The most common one being the equatorial. On the basis of etiology, it may be idiopathic, traumatic, lattice related, or iatrogenic types, which can be caused due to a heavy diathermy, a photocoagulation, a past planar vitrectomy, and refractive surgeries. And based on the configuration, it can be divided into a giant retinal tear without detachment, a giant retinal tear with detachment with a posterior flap. That is why the GRT is so important, because it may have a rolled posterior flap or an inverted posterior flap also. The third type is a GRT with a detachment with associated with posterior extensions at or within the tear margin. Now, why a GRT is special, why we have to discuss it separately from rest of the tears, it because it's rapidly leads to extensive retinal detachments. The posterior flap tends to roll over, fold, or invert, so it usually need a PFCL to manage. The most important thing is it has a very increased risk of a proliferative vitreoretinopathy. It requires a meticulous surgery to prevent complications, and almost all cases require a silicone oil injection. It is one of the few emergencies in retina. Uh, there is also a fellow eye involvement which occurs frequently, and redetachments also occur frequently in these cases.
I think this we already discussed. What are the systemic conditions or syndromes associated with GRT? Marfan sticklers, okay? And even in general examination, I think he missed it. You have to look for morphinoid habitus, tall, thin, arachnodactyly, yeah? So
Now,
this is also a very important question, okay? Please, has been asked multiple times, right?
now moving on to the vitreous substitutes, which can be a conventional, experimental, or newer. In the conventional ones, it can be gases or liquids. The gases may be air, C3F8, or SF6, while the liquids may be balanced oil solution, PFCL, and silicone oil. So, what is an ideal vitreous substitute? It should be transparent, it should be elastic, it should be biocompatible as it is vitreous itself, and it should be non-toxic. Now, moving on to the gases can be classified into non-expansile and expansile gases. And the non-expansile gases, the most common is air. So, it is mainly used intraoperatively during the fluid air exchange, facilitating the retinal detachment. It is easily available, it is very inexpensive, and the intraocular time is only 2 to 3 days. So that it cannot be used for long-term tamponade. While in the expansile gases, the most commonly used ones are SF6 and C3F8, which commonly used in the pneumatic retinopexy in a non-expansile concentrations for post-operative tamponade. It have a highest surface tension of 70 dynes per centimeter square for good tamponading effect. This table you can see, it shows what is the maximum expansion time, the duration, and the non-expansile concentrations. So for the air, the total duration is 5 to 7 days, while for a SF6, the maximum expansion happens at 28 to 48 hours, and the duration of 1 ml of pure gas is 1 to 2 weeks, and the non-expansile concentration is 20%. While for a C3F8, The maximum expansion occurs at 70 to 96 hours, and the duration is 6 to 8 weeks. And non-expansile concentration is 12%.
So, which is the long acting gas? And the shortest? See, you can't, you have to, now we are discussing in the context of vitrectomy, where you have to replace the entire volume of the vitreous, right? You cannot inject the expansile concentration because it's going to expand, right? Non-expansile or the diluted concentration we have to inject. We are just washing the vitreous cavity with the gas such that it has two things. One, you are replacing the vitreous, and also the gas property, it's tamponades. See, this pure expansile thing we used in cases where we had to displace the subretinal heme, like in PCV and those areas, even in pneumatic retinopexy. Those cases you can use only little amount. Correct? This diluted thing only you can wash off the entire vitreous cavity.
So in the figure, we can actually, this depicts that then the expansile gases forms a better tamponade than the silicone oil. As you can see in the first picture, there's a film of fluid between uh, the retina and the silicone oil, because the gas has a high buoyancy, so it has a high arc of contact. So in the second figure, you can see there is a C3F8 bubble, and there is an just inferiorly, there is a film of fluid which is between the bubble and the retina. So this is why, one of the contraindication of pneumatic retinopexy is inferior breaks.
So here, silicone oil forms a spherical bubble, okay, that configuration, whereas a gas forms a spherical cap, correct? So the actually speaking, the approximation is more with gas. If you see that lateral extent, it's completely approximated, but it is kind of absorbable, right? So the inferior retina remains unaddressed for quite some time. But if you say tamponade wise, which is the best tamponade, ideally gas, but silicone oil is kind of long standing because its volume doesn't change, right?
Now, another topic is a perfluorocarbon liquid, PFCL. So, it is fluorinated synthetic carbon containing compound that is clear, colorless, and odorless. PFCLs are immiscible with gases, fluids, and it have a surface tension of approximately 14 to 16 dynes per centimeter square measured against air. Its most remarkable property is specific gravity, which is higher than that of water, and its uses are it's used to displace subretinal fluid anteriorly through the pre-existing retinal brakes, which finally helps in drainage of the SRF. It helps in unfolding of the retina. It helps in unrolling of the GRT. It also stabilizes the posterior fold during a peripheral membrane peeling, and it can be also useful at the times of relaxing retinectomy. But what are the limits? Why there is a limitation to of PFXL use as a long-term tamponade? Because there's a direct toxicity, and it tends to induce inflammatory reactions. The most commonly used PFCL is octofluoropropane. Now talking about silicone oil, it was proposed as a vitreous substitute in 1958, which was first used in ocular surgery by Sibis in 1962. It is a transparent immiscible with water and has a refractive index of 1.4. The viscosity of silicone oil is expressed in centistrokes, so it can be of 1000 and 5000 centistrokes. So in our institute, the most commonly used is 1300. So silicone oil is also only substance currently accepted for a long-term vitreous replacement. The preferred uses of silicone oil tamponade is when there are multiple breaks, if there is resurgery happening, or if there is a complicated RD, like RD caused by a trauma or a giant retinal tear or an associated with coloboma and end off. The post-operative airplane high elevation travel can be planned in silicone oil, which cannot be done if there is an expansile gas or any present. And the complications may be emulsification of the oil, corneal decompensation, Bantam keratopathy, cataract, and glaucoma, as we have discussed earlier. The time of the removal of silicone oil is mostly around 3 to 6 months, and the anatomical outcomes and the visual acuity remain stable from 6 to 24 months.
Yeah, so all forms of that's what I think he put it. Any complicated RD, PVR, we prefer oil, right? They are known for recurrence resurgeries, right?
Now, touching upon a little topic of peripheral retinal degenerations, which can be divided into two subheadings, like the lesions which are predisposing to the retinal detachments and which do not predispose to the retinal detachment. So the lesions which do not predispose to retinal detachments are a microcystoid degeneration, a pavement stone degeneration, radicular degeneration, peripheral Duchenne, and pars plana cyst. The lesions which predispose to retinal detachment are lattice degeneration, snail tract degeneration, cystic retinal tuft, degenerative retinoschisis, zonal traction tuft, white with pressure, and white without pressure areas. So now, lastly, we will discuss about lattice degeneration. So it is usually present in around 8% of the population. It develops early in life, but the peak incidence is in the second and the third decade. It is more common in moderate myopes. The lifetime risk of retinal detachment in the person of lattice degeneration is approximately 1%. But degeneration is usually present up to 40% of the eyes of retinal detachment. So, what is a pathology? So, there is a discontinuity in the internal limiting membrane. There's a variable atrophy of the underlying neurosensory retina. The vitreous overlying the area of the lattice is syncytial, that is liquid, but it has a strong vitreous attachments at the margins. So, what are the signs? It is usually bilateral. That it is usually found in the tempora and the superiorly located between the equator and the posterior border of the vitreous base. There are spindle-shaped areas of retinal thinning. Like we can see in the figure, there are scleroid vessels forming the arborizing network of white lines can also be seen. Some lesions may be associated with snowflakes, whilst other can be associated with retinal holes, which may be atrophic. The complications, as we have discussed earlier, does not occur in most of the eyes. Atrophic holes have like 2% chance of leading to retinal detachment, and it gets increased if the patient is high myope.
And
So
there can be a formation of HST as the posterior border of lattice. Actually, like this patient, yeah, this patient had the same.
these are my references. Thank you. I want to thank Janani ma'am also for the guidance.
Thank you, Arush.